Hello, citizens of Internet. I am Dr. Ajit Virkud from Mumbai, India. I am a professor and ex-head of Department of Obstetrics and Gynecology. This is a channel that gives something extra. This podcast is inspired by the success of my textbook, which has been widely received by students and professionals alike. Each episode will delve into selected excerpts giving voice to my structured approach to topics in gynecology. Whether you're a student, a seasoned practitioner, or simply interested in the field of gynecology, I hope you will find these discussions both enlightening and engaging. Thank you for tuning in, and let's explore the world of gynecology together.
Welcome to the deep dive. So our goal here, our mission for this deep dive, is to give you a clearer, sort of more insightful understanding of P&D. And for this deep dive, we're fortunate to have insights from Professor Ajit Virkud, based in Mumbai, India.
Oh.
Yeah, and his experience gives us a really valuable clinical perspective. Weave in Professor Virkud's observations from his, decades of practice. This is all aimed at giving you, our listener, a really solid understanding. We're jumping straight into a really important topic. Something that's much more than just the baby blues. We're talking about perinatal depression, or PND.
Yeah, that covers depression during pregnancy and also in the period after birth, the postpartum period.
Exactly. And we've gathered quite a bit of information to really try and get a handle on this.
Mm-hmm. Our sources cover, pretty much everything from the official definition and how common it actually is, right through to some of the newer treatments coming out.
We're looking at diagnosis, risk factors, even the sort of wider economic impact, right?
That's right. Things like diagnostic criteria, what puts someone more at risk, and the costs involved.
We want to get past some common misunderstandings.
Yeah, and explore the nuances. It's a really significant health issue for parents, both expecting and new.
Okay, let's dig in. And actually, there's one idea I want to tackle right away, because I think it's quite harmful. It's this notion that women should just sort of grit their teeth and tolerate depression during pregnancy or postpartum, you know, for the baby.
Yeah, that's a really damaging myth. It's so important to understand that experiencing depression then, it has negative effects on both the mother and the child's development.
So ignoring it isn't helping anyone.
Not at all. Getting it properly diagnosed and treated is absolutely crucial.
Okay, so let's start with the absolute basics then. What exactly is perinatal depression? What does that label mean?
Right. So PND, perinatal depression, it's basically a type of depression that happens either during the pregnancy itself or after the baby is born.
Okay.
And the really key thing is that it meets the standard medical criteria for what doctors call a major depressive episode.
So it's not just a fleeting mood, it's a recognized condition.
Exactly. It's persistent, it's significant.
Right. So not just feeling a bit low for a day or two. What are the main signs, the symptoms, that might suggest someone is dealing with PND?
We're talking about symptoms that really interfere with daily life.
Yeah.
And they stick around. So persistent sadness is a big one. Also excessive anxiety, maybe feeling unusually irritable.
Okay.
Another key sign is something called anhedonia. That's the medical term for losing pleasure in things you normally enjoy.
Right, that loss of interest.
Yeah. And then changes in appetite, maybe eating much more or less, sleep problems, either insomnia or sleeping way too much. Feelings of guilt or worthlessness are also common.
Wow, that sounds incredibly hard to cope with, especially, when you're also dealing with pregnancy or a new baby.
It is, and sometimes the symptoms can become even more severe.
How so?
Well, in thankfully rarer but more severe cases, P&D can involve suicidal thoughts or even very occasionally thoughts about harming the baby. These are absolute red flags needing immediate help.
Okay, absolutely critical signs. So when does feeling down cross that line into being PND? Is there a specific timing doctors look for?
Yeah, the timing is important for the diagnosis. Symptoms can definitely start anytime during pregnancy. Now, under the older guidelines, the DSM-IV, it was classified as postpartum depression if symptoms started within the first month after delivery.
Okay, that specific time frame.
But the newer guidelines, the DSM-5, use the term peripartum onset, which acknowledges it can start during pregnancy or after. But regardless of when they start, the symptoms need to be there most of the day, nearly every day, for at least 2 weeks straight.
2 weeks. Okay, so it's about that persistence and how much it impacts daily life that really helps clarify how it's different from the baby blues people talk about.
Exactly. That's the crucial difference, functional impairment. The baby blues are usually milder, more transient. They tend to resolve within maybe a couple of weeks without treatment. PND is more severe, and really affects a mother's ability to function, to care for herself and her baby.
Got it. So we understand what it is, but how common is P&D really? Does it affect just a small percentage of women?
It's actually more common than a lot of people think. If you look at the general population of women who've recently given birth, studies show P&D occurs in about 13% to 17%.
Wow, that's quite significant.
It is. And that figure includes cases where the depression actually started during the pregnancy itself.
And does having P&D mean you're more likely to experience depression later?
Yes, that's an important point too. Many individuals who experience P&D are at a higher risk for recurrent episodes of major depression down the line. And it can also recur in subsequent pregnancies.
That's a sobering thought, the potential for it to be a longer-term issue. What about women who already have a history of, say, depression or bipolar disorder before getting pregnant? Are they more vulnerable?
Yes, absolutely.
Yeah.
For women with a pre-existing mood disorder, the risk is significantly higher. We're looking at maybe 20% to 30% experiencing postpartum onset specifically. And that number jumps up to around 50% if you include women who experience depressive symptoms during the pregnancy as well.
Wow. Okay. So if you're listening and you have that history, it sounds like being extra vigilant during and after pregnancy is really key.
Definitely.
What other things might make someone more susceptible? What are the main risk factors we should know about?
Well, there are quite a few factors that can increase risk. Having a family history of perinatal depression is one, so if your mother or sister had it.
Right. Genetics.
Yeah. And also, a personal history of P&D in a previous pregnancy is a very strong predictor. As we just mentioned, a history of major depression or bipolar disorder, especially if someone stopped their medication, is a major risk factor.
Okay.
Experiencing depression during the current pregnancy is another big one. And then there's psychosocial stressors, things like financial worries or maybe dissatisfaction in the relationship with a partner.
That makes sense. Stress during such a major life change must play a big role. What else?
A lack of good social support is really significant. Feeling isolated, not having people to lean on. Also, a history of abuse, past or present, or adverse childhood experiences, those can increase vulnerability too.
Okay.
And interestingly, even a history of significant premenstrual mood symptoms, sometimes called PMDD or severe PMS, has been linked to a higher risk of PND.
So it really sounds like a mix of biological, psychological, and social factors all weaving together. It's complex.
It really is.
You mentioned the postpartum period seems particularly risky. Is pregnancy itself seen as a risk factor for developing major depression, generally speaking?
That's a really good question and an important distinction. So while we definitely see this elevated risk around childbirth, the evidence doesn't really suggest that the risk of starting a major depressive episode is higher during pregnancy compared to other times in a woman's life.
Okay, so pregnancy itself isn't necessarily the trigger point for starting depression for the first time?
Not necessarily more than usual, but the postpartum period, that's definitely associated with a higher risk. Studies show the odds ratio is around 1.52, meaning about a 50% increased risk compared to non-postpartum periods.
Right. So that time after giving birth is where the risk really spikes. Why might that be? What changes after birth that could contribute?
There are several likely culprits acting together. One huge one is sleep deprivation. Caring for a newborn often means chronic lack of sleep, which can really mess with mood regulation.
For sure.
Then there's the immense stress of just adjusting to being a parent, the constant demands, and unfortunately for some women who needed medication for mood disorders before pregnancy, stopping or changing that medication during pregnancy can also increase the risk of PND afterwards.
Right, so it's this convergence. Hormonal shifts, sleep loss, huge responsibility, maybe medication changes, all hitting at once.
Exactly. It's a vulnerable time.
So let's shift gears a bit and talk about what's happening biologically. What are some of the key mechanisms that might make someone more susceptible?
Okay. Yeah, the underlying biology is, it's complicated, and we're still learning a lot. It's definitely not just one single thing. It's more of a mix of biological factors interacting with those psychosocial ones we mentioned.
Okay, but what are some of the main biological pathways researchers are focusing on?
Sure. One area involves the endocrine system, so hormones. Some women just seem more sensitive to those massive fluctuations in reproductive hormones like estrogen and progesterone that happen during pregnancy and especially after delivery.
Right, the hormonal roller coaster.
Exactly. Then there are epigenetic mechanisms, changes in how genes are expressed, potentially influenced by hormones like estradiol. Also alterations in synaptic transmission, that's how brain cells talk to each other using neurotransmitters like serotonin, which many antidepressants target, and also glutamate.
So it's not just hormone levels, but how the brain is actually communicating. What about brain structure or function? Are specific areas involved?
Yes. Brain imaging studies have shown altered activity patterns in women with PND in several key regions, like the amygdala, which is heavily involved in processing emotions, especially fear and anxiety.
Okay.
Also, the prefrontal cortex, important for decision-making, planning, emotional control. The cingulate cortex, another area involved in regulating emotions, and the insula, which relates to self-awareness and sort of internal body sensations.
The multiple interconnected areas seem to be working differently.
Yeah. And there are other systems, too. The immune system might play a role, with some studies finding altered levels of inflammatory markers. And then a really crucial area right now is research into neurosteroids.
Neurosteroids, okay.
Specifically, changes in levels of a neurosteroid called allopregnanolone, and sort of dysfunction in how these neurosteroids signal in the brain. And finally, the body's main stress response system, the HPA axis, often seems to be dysregulated or overactive in PND.
Wow, okay. That's a lot of different biological systems potentially involved. You mentioned neurosteroids and allopregnanolone are a crucial area. Can we dive a bit deeper into that? You said it relates to neural network dysregulation.
Yes, absolutely. This is where things get really interesting and linked to some of the newer treatments. So neuroactive steroids, or NAS, are hormones produced in the body that are critical for regulating the balance between excitation and inhibition in the brain.
Keeping things in equilibrium.
Kind of, yeah. They primarily do this by interacting with GABA receptors, GABA being the main inhibitory neurotransmitter in the brain.
Okay.
Now, in women with PND, studies have found altered functional connectivity, basically, how different brain regions communicate in several major networks, like the default mode network, which is active when our mind is wandering, the salience network, helping us pick out important information, and the central executive network, involved in focus and problem solving.
So it's like the communication lines between key brain hubs aren't working quite right in PND.
That seems to be part of the picture. And research has shown that women with PND have altered patterns of this brain connectivity even when they're just resting. And crucially, these alterations correlate with the levels of allopregnanolone in their system and also how severe their depression symptoms are.
Fascinating. So how do neuroactive steroids like allopregnanolone actually influence this GABA system?
They enhance the activity of GABA-R receptors. Think of them as boosting the inhibitory brakes in the brain. They can do this both at the synapse, at the direct connection point between neurons, and also at extrasynaptic sites, which are GABA receptors located outside of those main junctions. Enhancing both helps increase both rapid phasic inhibition and the more sustained tonic background inhibition.
You mentioned synaptic versus extrasynaptic GABA receptors. What's the main difference in their function?
So synaptic GABA-A receptors are mostly responsible for those quick on-off inhibitory signals that happen right at the synapse. Extrasynaptic ones contribute more to that constant underlying level of inhibition, the tonic inhibition, which helps set the overall excitability level of the neuron. Neuroactive steroids like allopregnanolone can effectively turn up the volume on both types.
That's helpful. And where do these neuroactive steroids come from originally?
They're actually metabolites breakdown products of pregnenolone, which itself comes from cholesterol.
Yeah.
And they do more than just act on GABA receptors. They can modulate other systems like glutamate and even act inside the cell nucleus to affect gene expression.
Wow, versatile molecules.
Yeah. But a key action for many of them is being what's called a positive allosteric modulator, or PAM, of the GABA-A receptor. That means they bind to the receptor at a different site than GABA itself, but their binding makes the receptor work better when GABA does bind. They enhance GABA's natural inhibitory effect.
Got it, like turning up the sensitivity of the receptor.
Exactly. And these neuroactive steroids are not just important for mood, they're also known to be crucial in how our brains respond to and cope with stress, both short-term and chronic stress.
So disruptions in this neurosteroid system, particularly with allopregnanolone and GABA, seem really central to the biology of PND.
That's definitely a leading hypothesis and a major focus of current research and treatment development.
Okay, so given how disruptive PND can be, what happens if it goes untreated? What are the consequences, not just for the mother, but for the baby, the family?
The consequences can be really significant, unfortunately, and quite wide-ranging. For the mother herself, untreated PND is often linked to things like increased smoking or substance use.
Kind of self-medicating?
Potentially, yes.
Yeah.
Also, higher rates of ER visits, less interaction and bonding with the baby, reduced safety behaviors like consistently using car seats, and even lower adherence to important pediatric care for the baby, like well-child visits and vaccinations.
Wow, that really paints a picture of how it can impact her ability to function and care for her child. What about the effects on the child's development long term?
Yeah, that's a major concern. Children whose mothers experience untreated depression during pregnancy or postpartum are unfortunately at higher risk for various developmental issues.
Such as?
Things like potentially lower IQ scores, slower language development, a greater likelihood of developing ADHD or other behavioral problems, and even an increased risk of psychiatric illness later in their own lives.
So it really can cast a long shadow on the child's future.
It can, yes.
What about effects during the pregnancy itself? If a mother is depressed while pregnant, can that impact the pregnancy physically?
Yes. Research suggests associations there too. Antenatal depression. Depression during pregnancy has been linked to a higher risk of preterm birth, having a low birth weight baby, developing gestational diabetes, or preeclampsia, which is a dangerous high blood pressure condition.
Okay.
And also potentially an increased rate of needing a cesarean delivery.
This just keeps highlighting how critical it is to identify and treat PND. You mentioned maternal mortality earlier, too. Can you expand on that link? It sounded quite alarming.
It is very alarming.
Yeah.
Tragically, suicide is a significant cause of death during pregnancy and in the year after childbirth. Some estimates suggest it accounts for up to 20% of all postpartum deaths.
20%? That's huge.
It is. And what's maybe even more shocking is that in the U.S., psychiatric disorders overall are now considered the leading indirect cause of maternal deaths. And the overall maternal mortality rate in the U.S. has, disturbingly, tripled compared to other wealthy nations in recent years. Untreated mental health conditions are a big part of that crisis.
That is truly shocking. It really reframes PND not just as a mental health issue, but as a critical factor in maternal survival.
Absolutely.
What about the broader societal impact? Is there an economic cost to untreated PND?
Oh, definitely. The economic burden is substantial. One major U.S. study estimated the cost of untreated perinatal mood and anxiety disorders, PMEDs, to be around $14.2 billion for just 1 year's worth of births.
Billion. With a B.
Billion, yes. That estimate covered costs from pregnancy through the first 5 years of the child's life. It breaks down to an average of about $32,000 per mother-child pair affected.
Wow. And what makes up those costs?
It includes increased healthcare spending for both mother and child, lost work productivity for the mother, and costs associated with the child's adverse health and developmental outcomes.
So investing in effective detection and treatment isn't just compassionate, it's actually economically smart.
Absolutely. The return on investment is potentially huge, both in human terms and financial ones.
Okay. So how is PND actually diagnosed, then? What criteria do doctors use?
Diagnosis follows the standard criteria for a major depressive episode. Generally, a person needs to have experienced 5 or more specific symptoms during the same 2-week period. And crucially, at least one of those 5 symptoms must be either persistently depressed mood or anhedonia, that loss of interest or pleasure.
Okay, so depressed mood or anhedonia has to be one of the 5. What are the other possible symptoms that count towards the 5?
Right. The other potential symptoms include significant weight loss when not dieting or weight gain, or decrease or increase in appetite nearly every day. Insomnia or hypersomnia, sleeping too much. Psychomotor agitation or retardation, basically being noticeably sped up or slowed down.
Okay.
Fatigue or loss of energy. Feelings of worthlessness or excessive or inappropriate guilt. Diminished ability to think or concentrate or indecisiveness. And recurrent thoughts of death, suicidal thoughts, or even a suicide attempt or plan.
And these symptoms need to be pretty consistent, right? A real change from usual functioning.
Exactly. So besides having 5 or more symptoms, including depressed mood or anhedonia, there are 4 other key criteria for the diagnosis. First, the symptoms have to cause significant distress or impair functioning socially, at work, or in other important areas.
Makes sense.
Second, they can't be due to the direct effects of a substance like medication or drugs or another underlying medical condition.
Yeah.
Third, there shouldn't be a history of manic or hypomanic episodes because that would point towards bipolar disorder instead.
Right, different condition.
And fourth, the symptoms aren't better explained by another mental disorder like schizophrenia or schizoaffective disorder. So again, it's about meeting those symptom criteria for a major depressive episode, representing a change lasting at least 2 weeks and causing significant problems.
Got it. It's a thorough assessment. Are there common tools doctors use to help screen for PND, maybe flag people who need that closer look?
Yes, definitely. There are several validated, easy-to-use questionnaires that are great for screening. Probably the most well-known is the Edinburgh Postnatal Depression Scale, or EPDS.
I've heard of that one.
Yeah, it's widely used. Another common one is the PHQ-9, the Patient Health Questionnaire 9, which screens for general depression symptoms. Sometimes the MDQ, or Mood Disorder Questionnaire, is used too, mainly to help rule out bipolar disorder, which can sometimes present like depression initially.
And these are relatively quick and easy to use in clinics.
Yeah, they're usually self-report, take just a few minutes, are inexpensive, and they give a good indication of whether further assessment is needed. They're really valuable for routine screening in prenatal and postpartum care.
Okay, good to know there are practical tools for catching it early. So let's talk treatment. Once PND is diagnosed, what are the standard approaches?
The standard of care usually involves a combination approach, really tailored to how severe the symptoms are and the individual's preferences. The mainstays are psychotherapy, talk therapy, and antidepressant medication.
Okay.
In some situations, other treatments might be considered, like specialized light therapy, TMS, that's transcranial magnetic stimulation, or even ECT, electroconvulsive therapy, for very severe, life-threatening cases.
Right. Let's start with antidepressants. How are they typically chosen and used for PND?
Well, if a woman has had previous episodes of depression that responded well to a particular antidepressant, that's often the first choice, provided it's considered relatively safe during pregnancy or breastfeeding, if that's relevant.
Okay, stick with what worked if possible.
Exactly. If there's no history, then the first-line options are usually the SSRIs, selective serotonin reuptake inhibitors, because they tend to have a better side effect profile compared to older antidepressants.
Like Prozac, Zoloft, those kinds of drugs.
Yes, drugs in that class. Yeah. If someone tries an SSRI, or maybe even a couple of different ones, and doesn't get enough benefit, then the doctor might consider trying an antidepressant from a different class, like an SNRI or others.
So it can sometimes take a bit of trial and error to find the right fit.
It can, yes.
Yeah.
And we usually say an adequate trial means taking the medication at a therapeutic dose for about 8 weeks to see if it's really working. Some guidelines might say 6 weeks, but generally around that time frame.
8 weeks, okay. But you mentioned earlier that standard antidepressants have limitations. Can you remind us what those are?
Sure. A major one is the delayed onset of action. It often takes, 6 to 8 weeks, sometimes longer, for people to feel significantly better and reach remission. That's a long time to wait when you're suffering.
Yeah, that sounds incredibly difficult.
And unfortunately, a significant number of people don't respond adequately to the first antidepressant they try. Even among those who do respond, many don't achieve full remission. They still have some lingering symptoms. Relapse is also a risk.
And you mentioned something about functioning lagging behind.
Right. Even if the core depression symptoms improve, improvements in overall functioning like energy levels, concentration, ability to engage in daily life, quality of life often take even longer to catch up if they fully do.
Okay. And what about side effects? Are they a big hurdle?
They certainly can be. Common side effects with many antidepressants include things like weight gain, sexual dysfunction, trouble sleeping, stomach issues, and sometimes this feeling of emotional blunting, like your emotions are sort of muted.
Right.
These side effects can be quite bothersome, and unfortunately, they're a major reason why many people stop taking their medication.
I can see why. So there are definitely challenges with traditional antidepressants. What about psychotherapy, the talk therapy you mentioned? How effective is that, especially on its own?
Psychotherapy actually has a very strong evidence base for PND, especially for mild to moderate cases. Several types have proven effective. Interpersonal psychotherapy, or IPT, and cognitive behavioral therapy, CBT, are probably the most studied.
Okay.
But there's also good evidence for mindfulness-based CBT, and even things like peer support groups or other group therapies. For women with mild to moderate depression, these therapies can definitely be used as a first-line treatment on their own without medication.
So therapy alone can be enough for some people.
Yes, for mild to moderate PND, it absolutely can be. Or it can be used in combination with medication, especially for more severe cases, or if therapy alone isn't quite enough.
That's good to know there are effective non-medication options. But what about for women with more severe PND or those who maybe haven't had success with antidepressants or therapy? Are the newer options emerging?
Yes, and this brings us back to those neuroactive steroids we talked about earlier, specifically allopregnanolone. This is a really exciting area.
How?
Because these neuroactive steroids work differently. They directly target that GABA-A receptor system, which seems to be just regulated in PND. By enhancing GABAergic inhibition, they can potentially have a more rapid and targeted effect on mood and anxiety symptoms.
Faster than traditional antidepressants, potentially.
That's the hope and what some of the data suggests, yes. A more rapid stabilization.
So, are there actual treatments based on this approved now?
Yes, there are 2 now that are FDA approved specifically for postpartum depression, PPD. Brexanolone is approved a bit earlier. Brexanolone is also a Schedule IV controlled substance like zuranolone, and it's specifically for PPD, but it's given differently. It's administered as an IV infusion.
Okay, so not a pill.
Right. It's basically an externally supplied form of allopregnanolone itself. And like the natural version, it acts as a positive allosteric modulator, a PAM, on those GABA A receptors, both synaptic and extrasynaptic.
Okay, an IV infusion of synthetic allopregnanolone. How does that work? How long does it take?
It's a continuous IV infusion that runs for 60 hours straight, so about 2.5 days.
Wow, okay.
The dose is usually titrated, starting low, increasing up to a target dose, typically 90 micrograms per kilogram per hour, and then tapered down. If someone has trouble tolerating it, the dose can be lowered.
60 hours is a significant commitment. What are the side effects like with brexanolone?
The most common ones reported are things like excessive sleepiness or sedation, feeling dizzy or lightheaded, sometimes vertigo, also dry mouth, flushing, or hot flashes.
Okay.
There's also a risk, though less common, of temporary loss of consciousness. In the trials where this happened, people recovered fully within about 15 to 60 minutes.
Loss of consciousness, that sounds quite serious. Does that require special monitoring?
Yes, absolutely. Because of that risk, brexanolone has a special safety program called REMS Risk Evaluation and Mitigation Strategy. It means it can only be given in certified healthcare facilities where the patient can be continuously monitored by staff during the infusion and for a period after, specifically looking out for excessive sedation or loss of consciousness.
Okay, so it's a very controlled hospital or clinic setting.
Exactly.
How does zuranolone, the oral one, compare in terms of how it's taken and its side effects?
Right, so zuranolone got FDA approval in 2023, also Schedule IV for PPD. It's chemically similar to allopregnanolone, but it's a synthetic analog with a slight modification, a cyanoprazole ring added. It also acts as a GABA-M.
And how is it taken?
It's taken orally, just once a day in the evening for a 14-day course. So much shorter treatment duration than typical antidepressants.
14 days, okay.
The standard dose is 50 milligrams, but can be dropped to 40 if needed due to side effects. Lower doses, like 30 milligrams, are recommended for people with significant liver or kidney problems. And a really key point, it must be taken with food containing fat, like a meal of 1,000 calories with 25-50% fat for it to be absorbed properly.
Take with a fatty meal, got it. Can it be used with other antidepressants?
Yes, it can be used either as monotherapy, on its own, or as an adjunct, meaning added alongside an existing oral antidepressant.
What about side effects for zuranolone? Is loss of consciousness a risk?
Thankfully, no episodes of loss of consciousness were reported in the zuranolone clinical trials. The most common side effects seen were things like somnolence or sleepiness, dizziness, some diarrhea, and fatigue. And importantly, there was no signal of increased suicidal thoughts or behavior compared to placebo.
That's definitely reassuring. Any other major warnings with zuranolone?
Yes. Because of the potential drowsiness and dizziness, patients are warned not to drive or operate heavy machinery for at least 12 hours after taking their dose.
Okay, that 12-hour window is important.
And also, because animal studies showed potential fetal harm, women who could become pregnant need to use effective contraception while taking zuranolone and for 1 week after stopping it.
Right. Important safety information. What about breastfeeding? Can women take either brexanolone or zuranolone while breastfeeding?
Based on the available data, yes, both medications are considered compatible with breastfeeding. The amount that gets into breast milk appears to be low.
Okay, that's good news for breastfeeding mothers. It really sounds like these neuroactive steroid treatments, brexanolone and zuranolone, offer a different approach, potentially faster acting for PPD. Are there others like this in the pipeline?
There is at least one other I'm aware of called Nora 520. It's an oral prodrug, meaning it gets converted into brexanolone or allopregnanolone inside the body. It's designed to have better absorption when taken orally and maybe last longer in the system. It's currently in development for severe PPD.
Interesting. So the field is definitely advancing. Now, thinking about managing PND effectively, it seems clear it's not just about finding the right medication or therapy.
Yeah.
Who else needs to be involved in a woman's care?
Absolutely. You know, managing PND effectively is really, as someone put it, a team sport. It ideally involves close collaboration between several people.
Like who?
Definitely a mental health specialist, like a psychiatrist or therapist, the woman's obstetrician or midwife, her baby's pediatrician. If she's breastfeeding, maybe a lactation consultant. Experienced nursing staff can be invaluable too. And crucially, the patient's immediate family or support system.
So a whole network around the mother and baby. Why is that multidisciplinary communication so vital?
It's just essential that everyone involved, the mental health provider, the OB, the pediatrician, is aware of the treatment plan and aligned. It ensures the patient gets consistent advice, avoids conflicting messages, and receives comprehensive support addressing all aspects of her and her baby's health.
Right, everyone pulling in the same direction. And you mentioned the family's role. How important is their involvement?
Oh, incredibly important. Family can provide vital moral support, just being there emotionally, but also practical support, helping with baby care, taking over household tasks to allow the mother to rest or attend appointments.
Yeah, that practical help must be huge.
It really is. And when the family also understands what PND is, that it's an illness, not a failing, and they understand the treatment plan, they can provide consistent encouragement and help fight any stigma the mother might feel. Their involvement makes the whole approach much more holistic and ultimately more likely to succeed.
This has been incredibly illuminating. It's so clear that perinatal depression is a major health issue with really serious consequences, but also that there are effective and increasingly innovative ways to diagnose and treat it.
It's quite remarkable how our understanding, especially of the underlying biology involving things like neurosteroids and GABA, is leading to these new therapeutic options.
Definitely. So if we were to boil it down, what are the key takeaways you'd want our listeners to really remember about PND?
Okay, let's see. First, PND is serious, impacting both mother and child significantly, and has a real economic cost. Don't dismiss it.
Right.
Second, that increased postpartum risk seems to involve a mix of genetics, hormone sensitivity, stress, and definitely sleep deprivation. Third, the biology is complex, but dysfunction in neurosteroid pathways, like involving allopregnanolone, and the GABA system seems key.
Okay.
Fourth, screening is actually pretty easy and cheap with tools like the EPDS or PHQ-9. We should be doing it routinely. Fifth, while traditional treatments like therapy and standard antidepressants have their place, these newer neuroactive steroid treatments, forvibrostanolone and oral zuranolone, offer new hope, often working faster by targeting that GABA system.
New tools in the toolkit.
Exactly. And finally, management really requires that team approach: mental health, OB, pediatrician, family, all working together. Strong family support is absolutely crucial for recovery.
That's a great summary. It really emphasizes the need for awareness, early detection, and comprehensive collaborative care. The potential impact of getting this right for mothers and families is just immense.
It really is. And it underscores the ongoing need to destigmatize PND. It's a medical illness, not a sign of weakness, and help is available and effective.
Absolutely. And Professor Virkud's final word is powerful. Don't dismiss a woman with postpartum depression as just another puerperal blues woman. It really drives home the seriousness.
It certainly does. A powerful reminder.
It really makes you think, doesn't it? Consider the implications of these newer biological treatments for how we understand and support maternal mental health. What might future research uncover about this incredibly complex connection between brain chemistry, hormones, stress, and the profound experience of becoming a mother? Something to ponder. Thank you for taking this deep dive with us.